Okay, welcome everyone. Welcome. So it's my pleasure and honor to introduce our speaker today, Professor Yelena Bodien, who is assistant professor at Vanderbilt University Medical Center. She's in the Department of Surgical Sciences, Division of Acute Surgery, Department of Neurological Surgery, and Department of Physical Medicine and Rehabilitation in Nashville, Tennessee. And she will talk today about post-traumatic confusional state, which is something that is very debated, and I can't wait to hear her expert opinion about that clinical diagnosis she has been working on for a few years now. Okay, Yelena, go for it.
Thank you very much, Dr. Snakers, and thanks everybody for joining. I see some familiar names on the call, and including some people who are very instrumental in the work that I'm going to be talking about today. So I'll make sure to point them out when we get to some of the slides where their work is really just critical for understanding the post-traumatic confusional state. I have no disclosures. And we'll give you just a brief outline of what I hope to cover today. So we'll do a little bit of background and historical context, because I think it's the history I think is relevant and also interesting for understanding how we got to the place we are today in terms of conceptualizing the post-traumatic confusional state, or PTCS. We'll talk about some definitions and diagnosis, prognosis, treatment, a little bit on pathophysiology, and future directions. So let's start by talking about what the trajectory of recovery from traumatic brain injury looks like. And many of you are probably very familiar with this, but I think it's good to get us all on the same page. So people with traumatic brain injury, they have a specific pre-injury baseline, cognitively, behaviorally, socially, in terms of participation. They experience an injury. And after that injury, often they go through a period of disorders of consciousness, and that's characterized by a diagnosis of coma, a vegetative state or unresponsive wakefulness syndrome, or a minimally conscious state. Now, it's really not clear whether everybody goes through all of these stages, or whether some people can actually skip over those stages or experience just a fleeting moment in one of those stages. But for the most part, we think that most people will go through at least some, even with mild TBI, some brief period of impaired consciousness. And then on the other end of this trajectory, we have what has been called emerging independence or ongoing recovery. It's a period of time that, where individuals are starting to try to integrate back into their prior lives, participating and dealing with maybe ongoing cognitive issues or psychosocial issues and so forth. The period that we're going to talk about today is this period in between, when consciousness, in terms of at least being able to do some basic following commands, has returned, but patients are still profoundly impaired and dependent. Now, I want you to think to yourself, and if you're very brave, use your chat to think about patients who are in this kind of intermediate stage of recovery. What are some of the common symptoms or presentations that you see in patients who have emerged from a minimally conscious state, but are really dependent and still in that phase where they need a lot of assistance? What are some of the symptoms that you think about? All right, I'm going to open my chat. Let's see what we have. Anterograde memory impairment, disorientation, confusion, disorganized thinking, communication. Excellent, 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 excellent. Poor safety awareness, confabulation, sleep problems, waxing and waning arousal. Excellent. Okay, so I think you guys have covered, for the most part, everything that I've put here. Patients are confused. They have memory problems. They have disorientation, poor attention. They are often agitated, restless. They sleep during the day. They're awake at night. Their symptoms fluctuate. They have this very complicated, and I would say colorful, presentation of symptoms that all of you have put so adequately into the chat. Yet, despite this, the term that we have traditionally used to describe this period of recovery is post-traumatic amnesia, which really only applies to one of the symptoms common to this phase of recovery, which is this memory piece. Other terms that have been used but not as frequently are the acute confusional state, the term delirium. But what hopefully I'm going to convince you of today, or you'll be convinced just by seeing some of the data, is that probably a more kind of precise term to use for this period of recovery is the post-traumatic confusional state, or PTCS. And when we say PTCS, what we really mean is the combination of all of these symptoms together that result in a confusional state after traumatic brain injury. And we can talk a little bit at the end about what this means for patients who are in a confusional state after a non-traumatic brain injury. But for today, we'll focus mostly on TBI. Now, you may be thinking to yourself, well, these are symptoms that are often seen in delirium. And when I see a patient who has post-traumatic amnesia, they also have these symptoms. So how do these terms all work together? And so the way that I like to think about it is that delirium is kind of this umbrella term that certainly does describe patients who have some of these symptoms, but typically from a very different cause. And it typically has a very different interpretation in terms of what an ongoing trajectory for recovery might look like. So PTCS kind of falls under delirium with a lot of overlap, but not perfect overlap. And then post-traumatic amnesia is a key feature of PTCS, but certainly doesn't describe all of the other things that are going on, although it is indeed part of the post-traumatic confusional state. Let's talk a little bit about where the term PTA comes from. So if we look back in the literature, descriptions of a confusional state go back to maybe the 1920s, maybe even before then, but this was kind of the best that I could find in terms of a real description of what these patients look like. So this is a paper from Dr. Simmons. And in this paper, he describes how some patients have a traumatic brain injury, they are concussed, a term that he uses, and then they recover, and within 24 hours or 40 hours, they're essentially back to normal. But then he describes a different type of patient. These are patients who, rather than making a rapid progress towards a mental state, which is characteristic of simple concussion, as he calls it, he remains, and the terms he uses are restless and irritable, drowsy, noisy, hallucinated, and there is gradual improvement with brief intervals of lucidity. They may talk for a few minutes or behave in a manner that's rational. And upon regaining function or their senses, they have an amnesia, so they can't remember this period of clouded consciousness. And what I want to point out in this beautiful description is not only the symptoms that all of you put in the chat just a few minutes ago, but also that he conceptualizes this as a period of clouded consciousness, which is why we think of PTCS as a part of the continuum of disorders of consciousness. And oftentimes when we write about this and we write about what does disorders of consciousness entail, what's the floor and what's the ceiling, we consider PTCS to still be within the broad umbrella of disorders of consciousness, similar to what Charles Simmons writes here. Another brilliant physician of that time was Dr. Richie Russell, and he did a comprehensive review of 200 cases of patients with traumatic brain injury. This is now in the 30s. And now, instead of having a clinical description of these patients, I think it's actually almost amusing to kind of read this excerpt. So he wanted to study them in a more statistical and a more quantitative way. And so he designs an interview, a questionnaire for patients, prints it on paper, and analyzes the features of 200 case records of individuals with severe traumatic brain injury. And following up on that work, what comes from some of these studies are more discrete and more kind of in-depth descriptions of the state. And I'll just share a couple more with you here. So patients are excited, dazed, and bewildered. The state may continue for days, weeks, or even months. And now we start seeing that these patients are also disoriented. They have problems with memory. They have problems with speech, mood, and so forth. And so from this work, we're now in the 30s, comes the first mention of post-traumatic amnesia. And it comes in a paper in 1943 published by Lancet. Now this is a duo collaboration between Simmons and Russell, and they describe post-traumatic amnesia as the end of the time from which the patient can give a clear and consecutive account of what was happening around him. So think about, it's that period of time where now they have not just one single memory, but a continuous or consecutive memory of what is happening and understanding of what is happening around them. But they caution that in using this kind of a description, they are basically, you should make sure not to accept the first memory as the end of the period of PTA, because you can have these islands of memory that are not contiguous. And you should be careful because just because a patient knows what's happening around them in the moment, it doesn't mean that they're going to be able to recall it later. So this is when they first put a term to this stage of recovery, and they use the term post-traumatic amnesia. Now, why do we think that amongst all of the things that they described in their clinical descriptions of patients who are recovering from head injury, from brain injury, why is it that they chose to focus on the memory impairment, on post-traumatic amnesia? And one reason, I think, is because post-traumatic amnesia was something that you could measure, right? If you can't measure it, then it's really hard to study it. But among all of those symptoms, PTA in a way can be measured. And the way that PTA can be measured is using either a retrospective or a prospective approach. So with a retrospective approach, it's essentially a clinical interview where you ask the patient, well, what do you remember about that time? And what do you remember before then? And what do you remember before then? And so the end of the period of PTA is the date of the first accurate account of the first memory after injury. So up to the point, from the injury to the point where the first memories are being laid that are actually being recalled subsequently, to this reconciliation of memory. Now, you're probably thinking to yourself that retrospectively trying to assess the duration of PTA isn't particularly precise. And you're right. This approach has the advantage of being able to be collected on every single patient who survives a brain injury, but it relies on judgment and memory. And as we saw before, islands of memory are not the same thing as continuous memory, and you can really have a lot of room for error here. And so the other way to collect information about PTA and to measure it is to do these prospective serial clinical exams. And so the end of PTA then is marked as a point at which the first accurate responses to a series of questions and memory questions and orientation questions are obtained. And this has much higher validity, reduces the variability. If you have two people administering the questionnaire, you're likely to get the same response. But of course, it's not always feasible to acquire this information prospectively. But I think this idea that you can measure PTA is why we really have had this term in our literature for so long. And subsequently, we have measures that have been developed that many of you are probably familiar to make this a little bit of a more objective assessment. We have the GOAT that assesses for both post-traumatic amnesia and orientation. We have a measure called the Westmead PTA scale that also looks at both orientation and at memory, and you need 3 perfect scores on 3 consecutive days in order to be considered out of PTA based on the Westmead, and then the orientation log, which is really focused more on orientation and less on PTA. So I wanted to give that background to kind of give you a bird's eye view of why the term PTA has been used for so long. And now we're going to move into how we got from PTA to using the term PTCS and what it really means. So let's talk about some definitions and diagnostic case definitions. Okay, so in 1992, Don Stuss and colleagues published a paper where they said that post-traumatic amnesia is really like a hypoactive or hyperactive delirium, and it includes problems with arousal, attention, in addition to amnesia. And then they subsequently published a paper where they identified the many different aspects of cognition that are affected in patients with PTA. So not just memory, but also attention, long-term recognition, and long-term delay. And from some of these studies, they came to the conclusion that rather than calling PTA, we should be calling it the post-traumatic confusional state. And that's where that term comes from. It comes from a series of studies in the 90s that showed empirically that PTA is really more than just PTA. And just to give you a little bit of a more modern piece of evidence for this, so we conducted a study back in 2020. We had a group of patients at our inpatient rehab facility who were emerging from the minimally conscious state, and at the same time were getting assessed for confusional state or for PTCS with a measure called the Confusion Assessment Protocol, which we'll talk about a little bit later. And we essentially found that every single person that was emerging from MCS had multiple symptoms of confusion that were kind of co-occurring with that emergent state. And those symptoms were cognitive impairment, disorientation, restless and agitation, and then a significant portion, in addition, had symptom fluctuation, problems with sleep, and psychotic type symptoms. So in addition to kind of that evidence early on in the 90s, we have some evidence to show that all of these symptoms are playing a role. And then I'll just share with you another study that was published leveraging data from the traumatic brain injury model system, where they collected a pretty comprehensive battery of neuropsychological assessments. You can see them down here. So looking at CBLT and looking at trails A and B, verbal fluency, and so forth. They even looked at the grooved peg test and looking at fine motor skills. And they divided patients into those who had, they consider them lower functioning PTCS. So these are patients who had a lot of symptoms of confusion. Higher functioning PTCS patients who had fewer symptoms of confusion but were still confused, and then emerged from the post-traumatic confusional state. And I've just highlighted here for you so that you can see that on tests of memory, of course, the patients do worse as, you know, lower PTCS, so the more impaired patients do worse. The patients who have fewer symptoms of PTCS do better. But you can also see that similar pattern on Trails A, for example, which, you know, is not really a memory test. You have to remember the instructions, but it's not really a test of memory, but you see the same pattern. So patients with multiple symptoms of confusion do worse than patients with fewer symptoms of confusion. And similarly, even on an oral verbal fluency test or a grooved pegboard, you see this same pattern. So the point being here that we have pretty substantial empirical evidence to suggest that PTA is not just about the memory impairment. So a couple of things have been done to address this. In a series of studies from Mark Shear's group and from Risa Nakasi, now Richardson, they looked at assessments of delirium, because delirium overlaps in its symptomatology with the confusional state, to see what symptoms of delirium are apparent in patients with traumatic brain injury, and what happens when you try to apply the DSM-4 criteria for delirium, which are listed here on the left, to patients with TBI. So DSM-4 criteria for delirium are disturbance in consciousness, a change in cognition that occurs over a short period of time, there's fluctuation, and there's evidence that this disturbance is caused by a psychological consequence of a general medical condition. We'll talk a little bit more about that caveat here. So they tried to apply this definition to patients with traumatic brain injury using a number of different assessments. And they noticed that in patients who met DSM-4 criteria for delirium, who had TBI, they were also disoriented on the GOAT, agitated on the agitation behavior scale, they had cognitive impairment, and a host of clinical symptoms assessed with a delirium rating scale. And so here are a couple of tables from that paper. What you can see in the top half outlined here in red is that patients who had a positive, so plus for this delirium diagnosis, had increased likelihood of having all of the symptoms we see here on the left. And similarly, scores on the agitated behavior scale, the GOAT, looking at orientation, test of cognition, and delirium, were predictive of patients having a delirium diagnosis based on DSM criteria. And the work that came from this was a development of the confusion assessment protocol, which combines items from multiple scales, looking at multiple different diagnoses that best differentiated patients who had a delirium diagnosis based on DSM-4 versus those who didn't after a traumatic brain injury. The confusion assessment protocol has 7 different composite items from it, looking at cognitive impairment, disorientation, agitation, and then symptom fluctuation, sleep disturbance, these are clinical symptoms, decreased daytime arousal, and hallucinations and perceptual disturbances. And in order to be considered confused on the confusion assessment protocol, you have to have at least 4 symptoms or 3 symptoms if one of the symptoms of is disorientation. What this means is that you can't just have amnestic syndrome. You can't just be disoriented and have a diagnosis of post-traumatic confusional state. But disorientation is clearly key to the post-traumatic confusional state, as evidenced by the fact that if you are disoriented, you only need 2 other symptoms to be considered in a post-traumatic confusional state. Bringing us back to some of the early work from Simmons in 1927, you can actually see that the clinical features that he picked out in his patients are mapped on very nicely to the types of symptoms that are being tested by the confusion assessment protocol. Now, the CAP is certainly not the only measure that looks at confusional state. There are others, and some of them are listed here across the top, but the CAP covers most of the features of the post-traumatic confusional state, paired with some of the, and it actually includes the GOAT. The delirium rating scale also covers several features, but it's purely based on observation and doesn't have any performance-based measures in it. So this is where I usually put a plug in for why I think it's so important that we use a standardized tool to assess confusion and to establish a diagnosis for the post-traumatic confusional state. These tools are objective, they're quantitative and reliable. You can use them to measure change over time. It really helps in communication with families if you can tell them exactly the symptoms and exactly the movement across the symptoms that are happening, helps with communication with the team. And I think, for me personally, a big bonus is that it facilitates research so that we can continue to understand the evolution of this condition going forward. So what has the CAP taught us about patients who are confused? Well, first, what you can see here in a paper published in 2005 is that patients who have a diagnosis of PTCS on the confusion assessment protocol compared to those who do not are much more likely to have all of these symptoms that are assessed by the CAP. So much more likely to have disorientation, cognitive impairment, fluctuation of symptoms, and so forth. So this is a bit of a validation. If you look at patients who are confused versus not, you would expect them to have more of these symptoms, and indeed they do. We've also learned by using a tool like the CAP, the pattern of recovery from the confusional state. And so this paper published in 2009 showed that the earliest symptoms to recover are the clinical symptoms of hallucinations and perceptual disturbances and sleep-wake cycle impairments. So the sleeping during the day, being awake at night, that resolves first. The things that are likely to persist over time is the cognitive impairment, which is probably not too much of a surprise, and the fluctuation in symptoms, which can be really problematic, especially as you're thinking about rehab treatment plans and so forth. So I hope that I've convinced you a little bit that when weighing whether to use the term and whether to assess post-traumatic confusional state versus simply post-traumatic amnesia, there are a lot of benefits to using the term post-traumatic confusional state and to assessing all of the symptoms associated with the confusional state rather than just memory impairment. Now, all of the work that I've kind of talked to you about over these years really led to an initiative by the American Congress of Rehabilitation Medicine Disorders of Consciousness Task Force to try to establish a formal case definition for the post-traumatic confusional state. And this effort was led by Dr. Mark Scheer and Dr. Doug Katz, who I believe is here, or at least was briefly. So I want to credit them because they truly were my mentors in trying to understand the post-traumatic confusional state. And this group came together and did an extensive review of the literature, trying to understand the phenomenology, the time course, pattern of recovery, implications of function, the upper and lower boundary of PTCS, and the pathophysiology of the post-traumatic confusional state. Now, the pathophysiology piece was actually kind of cut off from this project and became a separate project, which I'll talk about towards the end, but we were able to establish some criteria for these other aspects of PTCS. And so I'll go through them now so that you have a sense of what the case definition includes. So the first criterion establishes PTCS as a disorder of consciousness, first and foremost, that's characterized by all of the four core neurobehavioral features that includes impairments in attention, memory, disorientation, and fluctuation of symptoms, and recommends systematic serial assessment of all of these features in order to be able to establish a diagnosis for PTCS. Furthermore, in addition to these four core features, there are neurobehavioral features including emotional and behavioral disturbances, sleep-wake cycle disturbance, confabulation, delusions, and perceptual disturbances that can also, but don't have to accompany these four core features of PTCS. The PTCS diagnostic criteria is very specific in saying that the severity of the symptoms has to be such that they limit functional independence and they interfere with an individual's ability to cooperate in their medical care and their rehabilitation. They're unable to maintain personal safety, that came up in the chat, and unable to effectively interact with others and the environment. Furthermore, this condition cannot be better explained by another pre-existing, established, or evolving neurocognitive disorder, medical condition, substance intoxication, and so forth. And so this item really differentiates PTCS from delirium, which has a very different underlying cause, different underlying mechanism, and so forth. Again, something we'll talk about in a few slides. In terms of the lower boundary, PTCS can occur immediately after a traumatic brain injury, or as you transition from lower states of consciousness, coma, VS, UWS, and MCS, into higher states of consciousness. And sometimes you have fluctuation. And so you can look like you're in a confusional state at one moment, but actually have a more significant disorder of consciousness, appear to have a more significant disorder of consciousness in the next moment. And that is part of the difficulty in trying to care for these patients, is this fluctuating, waxing and waning state that they have. And finally, how do you know that somebody is out of a post-traumatic confusional state? They need to have recovery, significant recovery in all 4 of those core features of PTCS. And specifically, they have to be able to process simple information enough so that they can cooperate with their care and cooperate with their clinical team. They need to be generally oriented. They need to be able to recall some events or have some amount of learning of new information, and not have such substantial cognitive and behavioral fluctuations that they cannot participate in social interaction. So the cognition and the behavioral fluctuations have to resolve to the point where they can interact. So those are the key features of the post-traumatic confusional state that were published in 2020. And in the next slide, I want to talk a little bit about how PTCS and delirium are differentiated, because when we published this paper, we got quite a bit of pushback that we were trying to put another name on a condition that already exists. And so there was some interesting debate in the literature that you're welcome to look up between our group and other groups that felt like delirium should be the term to describe this state. And they were really considering PTCS as muddying the waters in terms of diagnosis. So what are some of the differences between PTCS and delirium? When we think of PTCS, when we think of a patient who has a profound disorder of consciousness and they are in a vegetative state or in a minimally conscious state, when they start exhibiting signs of confusion, agitation, symptom fluctuation, disorientation, I actually think that that's a great positive milestone of recovery after severe brain injury, because it means that they are starting to understand language, because they can actually answer your orientation questions, even if they're answering them incorrectly. They are starting to have some awareness of their environment, which is probably leading to some of their agitation and so forth. When somebody has delirium, that is actually typically an unanticipated decline in function. So they have some other condition, they end up in the ICU, and then they end up being delirious, not from the condition itself, but from some other factors that are surrounding them. Perhaps they have an infection or some other metabolic imbalance, and that's actually causing a decline in function that would be unanticipated for them, whereas PTCS is anticipated because it's part of the trajectory of recovery. So most likely for PTCS, there's an anatomic or a structural or functional pathophysiology that explains why patients are in a confusional state. And in delirium, it's often metabolic. In PTCS, we really have no targeted treatments available, especially pharmacologic treatments. In delirium, sometimes when you treat an infection, you actually have recovery from this delirious state simply from treating infection. Memory is a very big component of PTCS, not such a strong component for delirium. PTCS, again, may indicate a better ongoing outcome. Delirium is actually associated with a poor outcome. And so, as we talked about in the beginning, while PTCS falls under this broad umbrella of delirium, it really communicates a clear and common understanding of a very specific period of recovery after traumatic brain injury. If you're wondering what the published guidelines say about PTCS, they have in some ways adopted the term, this idea of a confusional state, and in some ways they have not. So the International Cognition Guidelines for Rehab Following TBI were updated in 2023. And part 1 of this guideline addresses post-traumatic amnesia. Now, I would have preferred that they used a confusional state, post-traumatic confusional state, but they continue to use the term post-traumatic amnesia in the guideline. But if you look at the actual guideline for assessment of post-traumatic amnesia, they recommend using the Westmead scale here, but then they also list a series of other scales that can be used to assess this condition. The confusion assessment protocol is one of them, And you can see here that they actually say specifically that you need to be doing serial standardized assessments, and suggest that you also need to be assessing for not just memory, but other behavioral components of the confusional state as well. All right, let's talk about prognosis. Now, there has been a lot of research on prognosis when it comes to PTA and a lot less when it comes to PTCS, but still I think enough to give us an idea of where the field can grow. So we can probably all agree that after traumatic brain injury, the injury severity predicts outcome after TBI. But what measures of injury severity predict TBI? So common ones are duration of coma, Glasgow Coma Scale, time to follow commands, and aspects of neuroimaging. What I find very interesting is that across multiple studies, the best, strongest predictor of outcome after traumatic brain injury is the duration of PTA. It beats out all of these other acute markers of recovery. And I won't go through all of the studies that have showed this, but I am going to put up this slide with several citations down here to convince you that PTA at various different cut points, depending on how you measure it, depending on how long you measure it for, depending on what the outcome is a predictor of global recovery, or global outcome. It is a predictor of disability. It is a predictor of employment. It is a predictor of productivity, amount of supervision. It really has been shown to be a predictor of a wide range of TBI outcomes. Well, what about PTCS? What happens when you compare the predictors of PTA duration against the predictor of severity of confusion as assessed by the number of symptoms that are present on the confusion assessment protocol on the outcome of employment? Interestingly, PTA duration, though associated with employment as an outcome, is a weaker predictor than the number of CAP symptoms. So PTCS is actually a stronger predictor of outcome, employment in this case, than PTA duration. Furthermore, when you look at some of our other common predictors like GCS or time to follow commands, the total score on the CAP, so this is again number of symptoms, is a stronger predictor in this case of employability, and it is also a stronger predictor of productivity when compared to time to follow commands, which is not predictive at all, GCS, which is not predictive at all, and age. So some strong data to show that the degree of confusion, the severity of confusion, is a strong predictor and probably a better predictor of outcome than post-traumatic amnesia. Let's talk a little bit about treatment. One of my favorite studies in this field, there's actually not that many studies to go on, but one of my favorite studies in this field is this one published by Jenny Ponsford's group, looking at whether or not you can actually improve function in patients with a confusional state if you provide them with a structured errorless learning procedural memory test. And what motivated this study was this idea that if a patient is in a confusional state, they can't lay down new memories. And so there's really no point in doing rehab with them because they're not going to carry over their information from session to session. They're too confused. No point in doing rehab. In fact, doing rehab can potentially be detrimental to them because it might cause agitation and behavioral dysregulation and so forth. So there might actually be a safety risk considered with pursuing rehab in patients who are in a post-traumatic confusional state. And this study, which is a randomized controlled trial, highest level of evidence you can have, actually proves otherwise. So in this study, they had activities of daily living retraining, procedural memory using errorless learning, and they showed, looking at the functional independence measure, that the FIM change score from baseline was better in the group getting the ADL retraining than in the group getting just the regular standard rehab program. Furthermore, they showed that this rehab protocol is not associated with increased agitation, so is not posing a safety risk. And pretty much based on this study and a couple of others, the INCOG guidelines for treatment for post-traumatic amnesia identify errorless learning, following standardized procedure, as grade A evidence, the highest evidence that you can have for treatment of the confusional state. Now, the INCOG guidelines have a whole list of other treatments. I'll just highlight a few of them here. Things like establishing a simple means of communication, providing therapy that is focused on the individual patient and focused on managing the agitation within the confines of the patient's ability, minimizing potential medications that could be either overstimulating or sedating. But you'll see that all of these other recommendations, they have a much lower grade of evidence because there's really not very much evidence in the published literature for treatment of PTCS, but this errorless retraining is at the highest level, partly because of that RCT. Now, individual rehab programs have taken it upon themselves to develop treatment programs locally for their patients in a confusional state. I'll just highlight a couple of them here. So Moss Rehab, this is freely available online, has a published protocol for patients in post-traumatic amnesia, PTCS, and there's a lot of nomenclature issues still here. Spalding Rehab Hospital is also developing or has developed a protocol for the confusional state that includes a whole series of interventions, each of which has a protocol associated with it and assessment approaches. So this is really focusing on minimizing restraints, looking at optimizing sleep-wake cycles. I'm just going through this rather quickly to give you a sense, optimizing orientation, using a standardized assessment daily, and so forth. And there's now even this really handy decision tree that you can use or you can adapt for your environment to help you identify whether a patient is in a confusional state. And what's really interesting here is that in terms of treating the specific symptoms, although they screen for PTA on the top end, they are really talking about treating a wide range of symptoms in these patients with PTA because, as we've talked about, they have lots of other behavioral cognitive issues as well. Okay. In the last few minutes, I want to talk about pathophysiology. So the case definition that was published in 2020, the original goal of that case definition was to also include biomarkers that might help us differentiate patients who are in a confusional state from those who are not, might help us also understand prediction of outcome a little bit better. And ultimately, you'd like to have treatments that are targeted towards pathophysiology rather than towards necessarily behaviors. So one of the issues that we have across the board, not just in PTCS, but across the board in TBI, is that many aspects of the pathophysiology are just unknown. The injuries are extremely heterogeneous. No two brain injuries are alike. And so we have a hard time trying to understand exactly what structural and functional aspects of the injury are associated with which symptoms and which long-term outcomes. So we broke this pathophysiology piece off from the main case definition and took it on as a separate study, also done by the ACRM Disorders of Consciousness Task Force. And to address pathophysiology, we first developed 5 questions related to diagnosis and prognosis. So these are PICO questions. They're formatted in a very specific way. So our diagnostic questions were trying to dissociate patients in PTCS from those who are a higher or a lower level of consciousness, and patients who have a confusional state from TBI versus other non-traumatic causes. So our first question we wanted to answer is for patients with TBI, do biomarkers such as structural imaging, functional imaging, EEG, biomarkers, protein biomarkers, genetic markers, do they differentiate patients in a post-traumatic confusional state from those who are not? Second question was, do they differentiate patients who have a post-traumatic confusional state from TBI from those who have a confusional state from another etiology? Now, you'll see here that even in our scoping review of the literature for pathophysiology, even though we all are very big supporters of using the term PTCS, because there is decades of literature on PTA, we included studies that looked at patients in PTA in our pathophysiology scoping review, because we're just not there yet. We just don't have enough evidence specifically looking at the PTCS, at patients diagnosed with PTCS. So the prognostic questions were around whether or not there are biomarkers that are associated with severity or duration of the confusional state, whether or not there are biomarkers for patients who are in a confusional state associated with cognitive or functional outcomes, and whether or not there are biomarkers that, when combined with measures of severity or duration of PTCS, predict outcome better than either alone. So we reviewed several thousand abstracts in 2 different rounds, and we're about to do a 3rd round to update the literature once more. So far, we have 53 articles that have been retained. I suspect we'll get a few more in this 3rd round. And the first piece of important information is that the majority of articles address the first PICO question related to differentiating patients with a traumatic brain injury who do versus do not have a PTCS. And the third biomarker, the third PICO question, sorry, which looked at biomarkers associated with different levels of PTCS severity or duration. And in a very kind of high level, I'll go through what are some of our findings. I'll give you the punchline up front. So while we would like to move towards having a biomarker that tells us, a specific biomarker that tells us whether or not somebody is in PTA or PTCS, or a specific biomarker that will tell us whether somebody is going to, well, the duration of the PTCS, or it will tell us something about outcome. There really was no single biomarker or even group of biomarkers that were able to give us diagnostic or prognostic information that can be used clinically today. Most of the studies that we found were not designed to answer these questions, and so we were pulling data from studies that were looking at a different question and trying to make some inferences about our questions. So going forward, studies that address these questions specifically will probably be really helpful, and they can start by looking at the biomarkers that we pulled from our scoping review as potentially having something to do with differentiating PTCS from non-PTCS and looking at the prognostic utility of biomarkers when looking at PTCS duration or severity. So we'll look first at PICO-1, and in PICO-1, these are biomarkers that differentiate patients with PTCS from those who are not in PTCS. We divided the studies in a couple of different ways. Here, I'll just divide the studies looking at moderate and severe TBI versus mild TBI. Now, the patients with mild TBI, we don't necessarily traditionally think of PTCS as something that happens in mild TBI, but patients in mild TBI certainly have periods, they might be short, but periods during which they are disoriented and have other clinical symptoms consistent with PTCS, even though it might be for a shorter period of time. So that's why we included the mild TBI cohort in our study. We did not exclude mild TBI. So in patients with moderate to severe TBI, we see that individuals who are in PTCS, when compared to individuals with a lower level of consciousness, so vegetative state, minimally conscious state, PTCS is associated with higher thalamic metabolic activity, a more intact default mode network. So the default mode network is a series of regions in the brain whose activity is coordinated in time when we are at rest or doing some internal reflection or so forth. So these are functional MRI studies. Patients go into the scanner, they're told to relax and not think about anything, very hard test. And then the analysis looks at these different regions within the default mode network and whether or not their activity is correlated in time. And so these regions have high correlation in the nodes, high correlation at rest. So the default mode network has been associated with multiple different conditions, including disorders of consciousness, and it appears to be more intact in patients who have a post-traumatic confusional state versus a lower level of consciousness. So in patients who have PTCS versus, this actually should be the upper boundary, PTCS versus higher levels of recovery, PTCS is associated with a slowing on EEG and a delayed event-related potential. So EEG signal in response to a particular stimulus. But a little bit confusing here because these two things are actually associated with the upper boundary of PTCS and these two with the lower boundary. In mild TBI, patients who have a period of confusion after mild TBI are more likely to have lesions on structural imaging. They're more likely to have decreased perfusion in the brain. And then I won't go through each of these, but there are multiple other blood biomarkers that are also associated with mild TBI. And so the bottom line here really is that while there are a number of different structural, functional, protein biomarkers that are associated with PTCS, no one particular biomarker appears to be the one that can differentiate PTCS from patients who are not in a post-traumatic confusional state. And in looking at PICO3, this is our prognostic biomarker, trying to identify whether different levels of severity or duration of PTCS are associated with a biomarker. We see that in patients who have a more severe post-traumatic confusional state, they have reduced cerebral blood flow, decreased activation in the temporal, medial temporal lobes, decreased activity on EEG, and an increase in a number of blood biomarkers. Again, suggesting that more severe, longer post-traumatic confusional state certainly has some pathophysiological basis for it, but exactly what that is that's going to cut across large cohorts is really unknown. And I think it's also worth bringing up that when we look at the pathophysiology of PTCS, it's very hard to tease apart whether it's the confusional state that is linked to the pathophysiology or simply that a more severe brain injury, putting the confusional state aside, is associated with these biomarkers. And so that's something that will have to be teased out in future studies. All right, so where do we go from here? So we've basically hopefully been able to show that PTCS is a stage of TBI recovery that is characterized by multiple different symptoms in addition to post-traumatic amnesia. And this requires serial standardized assessment for all of the symptoms that are common to the syndrome. Severity and duration is PTCS is associated with a series of functional outcomes and with biomarkers. In terms of future directions, the case definition that we provided was really based on a combination of evidence. Mostly it was based on a literature search review, but also with expert opinion involved. And so it hasn't really been well vetted in clinical and research settings. We don't have enough data to really be, to have the empirical evidence behind, including all of those different symptoms in the case definition and so forth. So I think an area of future research that can really be pursued by even clinicians, if we can get standardized behavioral data on this patient population, large enough data sets, we can really start understanding the symptomatology better and trying to validate the case definition. So we also have very minimal information on non-traumatic etiologies leading to confusion. And this is something that comes up all the time whenever I talk about PTCS or I talk, give this type of a talk. It's like, well, what about non-traumatic? These patients have very similar symptoms. Why are you only studying TBI? And it's possible that there is a lot of overlap. Also possible that they are really distinct conditions, something that needs to be studied further. And finally, at the end of the day, if we really want to be accelerating this recovery period or preventing it entirely, then we're going to need a lot more data on the pathophysiology and the symptom profiles to be able to develop some targeted treatments to help get people through this phase of recovery, which, as you know, can be very distressing both to them, to their families, and to the clinical teams that are trying to work with them on a daily basis. And with that, I will say thank you, and I'm happy to take some questions. I see there's some in the chat, and I'll hand it over to Dr. Schnakers to moderate the Q&A.
Thank you, Elena. That was awesome. I really love this this talk that really give like a great overall perspective on this new category. And I feel it's really even very interesting to see that when you look at pathophysiology, there is not that many studies, even for PTA. I was expecting like much more. Of course, there is like neuroimaging that was in the 90s, so maybe that took some time. But I'm kind of very struck by that. The other thing, of course, obvious confounding factor is that even though, in PTA, when you take the literature about PTA, even though PTCS include memory issue, PTA most likely have patients that were not confused, did not have confusion. So that's definitely something else that, unfortunately decrease our understanding of how that differentiates from other pathologies. What about acute confusional state? Is it something that, because I know it was discussed at some point, but I don't know what is the debate about the name right now.
You mean the term acute confusional state?
Yes.
I think that term is used when there are non-traumatic etiologies involved as well. So if you're
So am
looking
I
at
allowed to use
oh
acute confusional state for non-traumatic brain
for
injury?
non-traumatic, I don't think there are great guidelines for that or great papers to suggest. I think that I personally have used it as well, and we've even I think written in a couple of chapters that we've published. What is the right terminology? I don't think there is a right terminology necessarily for neurologic conditions that result in a confusional state but are not from a traumatic brain injury. So I've used acute confusional state. I'm curious. There are others on this call that are also experts in this field. I'm happy to have others weigh in. But I think it's probably an appropriate term to use and better than using PTA because it at least encompasses the full constellation of the syndrome. But I think when you're talking about TBI, PTCS is probably more appropriate. Oh, and
Okay.
good. Dr. Katz has come off has turned on his camera, so I'm curious to hear what he has to say.
Hi,
Hi. Can you hear me okay?
yes.
Yeah, so personally, I think a lot of other people use acute confusional state and delirium synonymously. And sort of within the Venn diagrams, I would consider post-traumatic confusional state a subtype of an acute confusional state. Now, albeit it can last a long time, more than what we often consider acute, but I would consider it a type of acute confusional state. It really depends on these things have not been well defined, but I think historically, acute confusional state and delirium have been used largely synonymously, and we're just talking about one type of confusional state or delirium, and we can call it a post-traumatic delirium in my mind, the way I use the terms.
Yeah, and I think that we have also a very interesting question about aging. So what about, more older population who have TBI, who have severe acquired brain injury, and then go through this type of entity? Is it something that is slightly different in this population? Is the profile that needs to be treated different because maybe the confusion is more acute? Is it an interaction between delirium and post-traumatic confusional state?
It's a great question. And to their point, most studies certainly don't isolate the older group. Sometimes they even exclude the older group. So I am sure that there is, an overlap or an interaction, as you put it, between what happens to patients after they experience delirium from being in the ICU for a really long time, from all of the environmental factors that are contributing to disorientation and so forth. And so it's been interesting because here I'm at Vanderbilt University Medical Center now, and there's a very large group that studies delirium here, and a couple of studies going on trying to tease out in patients with TBI how much of their long-term issues are aligned with the post-ICU syndrome, just the fact that they are on sedation for so long and they're deconditioned for so long, plus they have the confusion on top of that, trying to tease those two things apart. Do fewer days on the ventilator results, in fewer days of confusion down the road, things like that. So I think that the simple answer is that it's not so easy to know right now how to disentangle those things, especially with people with these prolonged ICU stays. And we certainly need more data. But in terms of specifically the older adults, for an older adult who was oriented and did not have significant memory problems prior to their TBI, I don't know that we would expect them to have, immediately after a recovery that's that different. And especially if we're talking about adults in their 60s and 70s, many of them have excellent recoveries, even with profound injuries, if they were healthy cognitively and so forth beforehand. So I wouldn't say that just because you have an older adult population with a TBI, you would expect them to have necessarily longer PTA or PTCS if they were fully cognitively intact prior to the injury. But again, something that certainly needs to be studied, and we need these larger cohorts to be able to do it.
To tell you the truth, that has been something that has been on my mind. I don't know for you and for you guys, but when I assess older population, they have a very specific profile, DOC patient I'm talking about, where they have a vigilance issue that is much severe. Patients sometimes respond to comment with their eyes closed. In these aging population, they have a very difficult time to have this eye opening and vigilance there. While it's less the case, I feel, in younger population, and that has never been really studied and should be studied. But definitely lifespan is a big deal.
Yeah.
And pediatric, I mean, we'll not even go there. But we have a last, I think, a comment slash question or question slash comment, which is a very recently met reviewer who asked me to change PTCS to PTA with reference to the INCOG guidelines. It bothered me, but I did it. We understand, okay, guys? We understand, guys, why you do that. We do it too. It's fine. It still sits with me. Not sure there is much to do about it at this point when the terminology is debated. Any recommendation?
Yes. So first of all, thank you for bringing this question up because it's definitely not the first time I've heard something like this. And here's what I would say. I think that if your data, if your assessment tools are assessing the confusional state and you're assessing all the symptoms, and you're showing this person had not just a memory, amnestic syndrome, but also all of these other syndromes associated with PTCS, probably what I would have done is pushed back a little bit to say, look, there is no right, agreed upon term in the literature, but we do have plenty of literature to suggest that PTA is much more than PTA. And so I maybe would have done one more round with the reviewers to say, here's the case definition. It includes all of these symptoms. These are also the symptoms that we assessed for in our study. And so our patients truly are in a confusional state, in addition to having PTA, and we'll report the PTA, we'll report the GOAT scores, we'll show that they're disoriented. But in order to accurately paint the picture of and to describe the patients, the term post-traumatic confusional state is just more accurate. And maybe they would have pushed back again, and then you would have had to capitulate and use PTA anyway. But I do think that people need to be educated a little bit about this because PTA has been the term used for 100 years. They are just unwilling or uncomfortable with switching to using another term until they're educated a little bit more about it. So I think that's maybe one more round with the reviewers. But ultimately, I agree. It's a little bit of an uphill battle.
Particularly,
Yeah.
Not everyone is Professor Bodien, and so sometimes you feel like, okay, maybe I should bend for that article to
Yeah,
come out.
exactly.
And I really
You might have
get
had
it
10
in the
other
beginning
things
of
you
my
had to.
career, it was the same, so I understand. I will just ask a very last question that I find very interesting, and it actually has 4 thumbs up. Has anyone looked into visual impairment and their impact on confusion disorientation? We have found anecdotally that patients with significant visual impairment have persistent confusion, which is most likely that's the same, but
yeah, I
that's very
don't
good question.
think it's a great question. I don't think it's been looked at. I think it's sometimes really hard to assess visual impairment in these, especially the patients who are really confused. It's really hard to even get to the question of how impaired their vision is if they're unable to reliably report. And so in general, in patients with DOC, it's very similar. How much that contributes, I think, has not been, to my knowledge, well studied. And similarly, I think there's a question about gender. Similarly, I think some of those things just haven't been worked out yet. So great ideas for future studies.
Yeah, well, there is a lot of things to investigate for PTCS, and that makes it very, very exciting. But it was wonderful. Thank you so much, Professor Bodien, Helena, for this talk. It was really wonderful. Thank you for your additional comment, Doug, the cats. That was a wonderful overview of the topic. And if people are interested, I will definitely put you in contact with them for answering maybe more questions. A last remark is that we are thinking about the program for next year, so look out for an email you will receive most likely for January. We will have another webinar at that point. Thank you so much, everyone, for attending. There were a lot of you interested, I know, in the topic, and thank you so much again, Professor Bodien, for that beautiful talk.
Thanks. Good to see everybody.
Thank you. Bye, everyone.
Bye-bye.
Bye. Bye-bye.